So, am I audible?
Yes, sir. We can start.
Yeah, we will start now. So, good morning, everybody. I am Dr. Ashwin Kulkarni from Department of General Medicine, Ramaya Medical College in Bangalore. So, today I'll be talking about the ECG interpretation. So, the deciphering ECG module is going on, and today's topic allotted to me is myocardial ischemia and infarction, the interpretation of the ECG. Okay, so the overview of today's class. So in today's class, we'll be discussing a little about introduction of myocardial ischemia and acute coronary syndromes. You should, we'll read about ECG changes in acute coronary syndromes, localization of the artery involved, ECG changes in cardiac ischemia, and also a little bit about how to interpret myocardial changes if there is a bundle branch block. So the objectives of today's class will be at the end of the class, you should be able to enumerate ECG changes in hyperacute and acute and old myocardial infarction, describe the localization of the artery involved, and also describe about something about Wellen syndrome and something about De Winter syndrome. The main purpose of conducting this module is for orientation of the students. So basically this module is for the undergraduate medical students, it is for the interns and also for the postgraduate students, because you people are working in the casualty, you are the first point of contact for a lot of patients, and ECG is one such thing which is very important for all of us to know regarding how to manage the further things. So what is myocardial infarction? It is the necrosis of a portion of myocardium due to sudden occlusion of a branch of the coronary artery. Histopathologically, an infarction region consists of a central core of necrotic tissue surrounded by a zone of injured tissue and which is surrounded by a zone of ischemic tissue. So why is this important? So it is important because in any ECG, you can have a combination of ECG changes of a necrotic myocardium, a zone of injured tissue. You should know what are the ECG changes happening in the injured tissue. And also you should be aware of what are the ECG changes happen in the zone of ischemia. The ECG remains a key investigation in the diagnosis of MI and the acute coronary syndromes, as you all of you know. ECG abnormalities can be related to depolarization as well as repolarization of the myocardium. This slide is very important. I want you people to see this slide very carefully. ECG is neither 100% sensitive nor specific for acute myocardial infarction. We are conducting this ECG module for myocardial infarction and ischemia, but you should remember that ECG is never 100% sensitive. And always ECG has to be analyzed keeping in view the clinical context, the clinical condition, the comorbidities of the patients also. It is very important for you to know that single ECG for MI, the sensitivity is around 60% and specificity is around 90%. Once again, reiterates that you have to know about the clinical context, the symptoms, and the clinical presentation. It was seen that normal ECG does not rule out acute coronary syndromes. In fact, 1 to 6% of the patients who had normal ECGs were proven to have MI, and around 4% whose ECGs were normal were found to have unstable angina. So you should remember that ECG, especially when you are interpreting cardiac ischemia, infarction, you have to correlate with the clinical condition and the symptoms. So as you all know, acute coronary syndrome is a spectrum of clinical presentations which is associated with rupture of atherosclerotic plaque. It can lead to partial or complete occlusion of the coronary artery and its branches. So as you all know, just for a refreshment of undergraduate students, it includes STEMI, where there is, that is ST elevation myocardial infarction, where there is the elevation of the ST segment. Usually, STEMI denotes a transmural infarct. That's a full thickness infarction of the myocardium causes ST elevation. Whereas the other two types of acute coronary syndromes, they are also acute coronary syndromes, but the ST segment is not elevated. It might be normal or it might be depressed, or there can be just T wave abnormalities. So those are, we call it as non-ST segment elevation MI, and the other one is unstable angina. The difference between the two is in non-ST elevation MI, there is evidence of myocardial injury, which is manifested as elevated cardiac enzymes like troponin T or troponin I or creatinine kinase. Whereas in unstable angina, there is ischemia ongoing, but there is no evidence of myocardial necrosis. So this is a very, very important slide for you all. So what are the diagnostic ECG criteria in MI? So these are the four things. So whenever a patient presents to you with chest pain or anginal equivalents, it could be sweating, it could be breathlessness, it could be epigastric pain, it could be chest pain radiating to the left shoulder, jaw pain, any of such anginal equivalents, we have to look at these four parts of the ECG. The first and most important part is the ST segment. As you all know, ST segment is a segment between from the QRS complex, the end of the QRS complex to the end of start of the T wave. So this ST segment is extremely important because it is the one of the most sensitive areas of repolarization where the anything related to ischemia or MI can reflect. So you have to look at ST segment. There can be ST segment elevation or there can be ST segment depression. So both are equally important. In our future slides, we'll look about how to tell an ST segment elevation or how to tell whether there's a ST segment depression. In this picture down, you can see there is the elevated or elevation of the ST segment also. In the next slides, we'll see them further. Next important wave you should look for is the R wave. So what has happened to the R wave? In the previous ECG modules, it has been they have explained to you regarding what are these waves, how these waves originate, and what do they represent. So R wave in myocardial infarction, whenever there is necrosis of the myocardium, so there will be progressive diminution of the amplitude of the R wave. So ST segment elevation or depression, progressive loss of R wave, and T wave changes. This is also an important aspect here. So T waves, usually they are upright waves, but in ischemia there can be inverted waves, there can be which are symmetrical and inverted, and sometimes there will be tall T waves, which we'll discuss further. And another important aspect is the appearance of Q waves, the capital Q, that is a deep Q waves, which are more than 25% of the height of the R wave. So this description is quite important. When do we say the Q wave are significant? If the Q waves are more than 0.04 seconds in duration or more, they are said to be abnormal. And if they are quite big enough, that is more than 25% of the R wave, we call them as significant. So whenever you see an ECG suspect with a patient suspected of MI, look at the ST segment, look at the R waves, look at the T waves, and also look at the Q waves. So based on all the four changes of these four segments, you can decipher what could be the possible cause. This is a beautiful picture where we have compared. So this is a normal ECG, a P wave, QRS complex, and a T wave. Here you can see there is elevation of ST segment. Usually ST segment is isoelectric. So here this is a J point and this is the ST segment. But in MI, the initial aspects, the J point elevates and there is an elevation of the ST segment, as you can see here. T waves are also slightly tall. So this is a typical ST segment elevation. As time progresses, the Q waves, which are minimal here, they start becoming more and more prominent. They go down. You can see there the amplitude is the depth of the Q wave is increasing, and you can also compare the heights of the R wave. The slightly diminuting in the height, and ST segment is there. So elevation is there, and the T wave, which was upright here, slightly goes down and it becomes slightly inverted. In future evolution of the MI, you can see here there is the Q wave becomes deeper further. There is a bigger Q wave. ST segment starts to slightly come down to its isoelectric line, and the T wave progressively becomes more inverted. Here you can see a beautiful T wave inversion. These are also called as coronary T waves. The T waves are inverted. You can see the limbs are symmetrical and it is pointed. So these T waves are called as coronary T waves. So what are the points? You should know that they are inverted, they are symmetrical, and their limbs are equal. So it's a pointed. So this is a coronary T wave. And here it's the fully evolved MI where you can see ST segment has come down to normal. T wave has come down to normal. But the point where that it signifies there was an infarction, there is a Q wave, which is a deep Q wave. So this suggests that there was a old anterior myocardial infarction. So this is an important slide. As I mentioned, there are three areas. One is the area of necrosis, area of injury, and area of ischemia. You are supposed to know what are the few ECG findings in each area so that you can interpret the ECG better. So whenever there is infarction, there is necrosis, the myocardium is dead. So there is no alive myocardial region in that area. So that area doesn't conduct the electricity or the electric vector. So it causes a hole in the myocardium. It's like that, a electrical hole. So this is manifested by a big Q wave, a pathological Q wave. Sometimes Q wave and S wave combine and forms a QS wave. There is loss of R wave height, and also there can be notching of the QRS complex, and sometimes there can be conduction block. Either it can be a right bundle branch block or left bundle branch block. For practical purpose, you can remember that if there is a deep Q wave or a QRS complex with loss of R wave, it generally signifies an evolved old necrosed myocardial tissue. Whereas in injury, where there are myocardium is undergoing injury at present, there is infarction. So it manifests initially as tall and broad T waves. The T waves tend to be tall and they tend to be broad. And gradually, as I mentioned in my previous slide, there will be ST segment elevation, there will be J point elevation and loss of S wave. So practical purpose, initially there will be broad T waves followed by ST segment elevation. So these are the two most important points of myocardial injury. Ischemia. So when there is ongoing ischemia, generally the ST segment tends to be depressed and the T wave tends to be inverted. As I mentioned in my previous slide, the T waves are deep and symmetrical. So these are the few changes: QS complex and loss of R wave and notching of QRS complex in the area of infarction. Tall T waves, ST segment elevation and loss of S wave in the region of injury. And ischemia manifests as ST segment depression and T wave inversion. So this is an important slide for you all. So how do we tell that how much ST segment should be elevated to be called as MI? So ST segment elevation at J point with convexity upwards should be present in two or more contiguous leads, and the height of the ST segment elevation should be 2 millimeters in V1 to V3. If you see the segments of V1 and V2 and V3, the elevation should be more than 2 mm. And in other leads, even if the ST segment elevated is more than 1 millimeter, we consider it as significant. But you should remember it should be at least in 2 or more contiguous leads. ST depression can be seen in subendocardial infarcts, the small infarct where only subendocardium is involved. And as I mentioned, the T waves will be coronary T waves and tall T waves, which shows a hyperacute infarction. So this is a picture which shows the evolution of MI, a normal ECG. There is ST elevation. There is ST elevation with Q wave beginning and R wave receding. A deeper Q wave and a T wave inversion. And these are from acute, few hours, few days, and these are the finally few days. So this is one more picture where the evolution of MI is shown. So the earliest change is tall T waves. Then after 4 hours, there will be ST segment elevation. Then 6 hours, 12 hours, the T wave begins to appear. In around 3 days to 3 to 4 days, ST segment starts receding and T wave starts getting inverted. At 2 weeks, you have a Q waves and a T wave and a slightly elevated ST segment. And after a few weeks, Q wave and T wave inversion persist, whereas ST segment becomes normalized. So this evolution is important for you because at the time when you see the patient, it differs. So if you see the patient initially, the patient may be in the hyperacute phase. So you should be knowing what are the ECG changes in the hyperacute infarction and so on. So this is a very interesting slide where you should know that not only the MI, but there are other causes of ST segment elevation. So the mnemonic for this is elevation itself, ST elevation. So it's elevation mnemonic. E stands for electrolyte abnormalities, like generally hypokalemia. L stands for left bundle branch block. A stands for aneurysm of left ventricle, which also causes ST elevation. V stands for ventricular hypertrophy. Arrhythmias like Brugada syndrome can have ST segment elevation. Takotsubo cardiomyopathy, also called as stress cardiomyopathy, which we see sometimes in COVID patients, even that can have ST elevation. And injury, if there is a road traffic accident with cardiac contusions, so even that time you can have ST elevation. And finally, vasospasms like Prinzmetal's angina can also have ST segment elevation. So you should remember this mnemonic of elevation to know the causes of ST elevation. So ST segment, as I mentioned, elevation and T wave changes. The point here I want to make you is if there is a persistent ST elevation with Q waves. So even after a few weeks, if you still see the ST segment is not coming down, this indicates that there is a severe left wall echinacea or an ekinetic segment or a dyskinetic movement, dyskinetic area of myocardium, which can cause persistent ST segment elevation, or also ventricular aneurysms. So these aneurysms where the ventricle wall becomes dilated, that also can cause ST segment elevation. T waves, as I mentioned here, it gets inverted and it takes almost weeks to months to get normalized. And Q waves are suggestive of generally evolved MI and also chronic old MI. So this is an important. So when can we make a diagnosis of myocardial infarction? So as I mentioned, the presence of ST segment elevation or depression, which it fulfills the criteria of more than 2 mm in V1 to V3 and more than 1 mm in other leads, or there is a development of new LBBB. So if a patient has chest pain and you see in ECG there is an LBBB, and if you have an ECG which shows that there was a prior normal ECG, so this new onset LBBB has to be taken in context of a new LBBB, and we have to treat this patient like a normal patient of STEMI, or even development of new pathological Q waves. So these 3 points are required to make the diagnosis of myocardial infarction. So as I mentioned, changes in ECG should be present in at least 2 or contiguous leads, and confirmation has to be done by cardiac enzymes, echo, or coronary angiogram. So this slide tells you some new variations like what is the amount of ST elevation, that is especially in V2 to V3. If the patient is a male patient and is less than 40 years, we have to consider 2.5 millimeter elevation as significant. And for more than 40 years, even 2 millimeter elevation is considered significant. Whereas in women of all ages, more than 1.5 mm itself is important. So this has been told in many books, but still, if you get ST elevation, so even you may not fulfill this criteria, but still out of benefit of doubt, we have to repeat ECG and treat him like a patient of MI, because as I told you that ECG is a dynamic parameter and it keeps changing every minute to minute. So all these criteria you should be knowing, but always you should interpret in the clinical context. So this is a typical ST segment elevation. So how does it look here? So what is this? This is a tombstone. So this elevation is classically described as a tombstone elevation. So why I'm telling you is these kind of things, you will see them in your practice, and also many times they ask in multiple choice questions with various signs. So this is a typical tombstoning of ST segment. And here you can see various types of ST segment elevation. So all these 6 are ST segment elevations. So especially this frowning variant of ST segment elevation, where it looks like a frowning, is most pathological as suggested in some books. So coming to hyperacute MI, so this MI is very difficult to identify because the patient may not have come to the hospital itself, but still you should be knowing. So hyperacute MI has very tall and wide T waves. So what is the mechanism for this tall and wide T waves? Because they tell that the cells of the myocardium have intracellular hyperkalemia. So this intracellular hyperkalemia leads to tall and wide T waves. So these T waves are taller than the R waves. Increased amplitude of R wave slope elevation of ST segment. So gradually ST segment becomes elevated. Theoretically, in some books, it mentions increased ventricular activation time. So what is this? It is a time taken from the beginning of the QRS complex to the R wave. So the R wave leans right. So R wave is slightly tilts towards the right side in hyperacute phase of MI. So these are the three important things, that is tall and wide T waves because of intracellular hyperkalemia of the cardiac cells, increased amplitude of R wave, and slope elevation of ST segment, and increased ventricular activation time. So these are the signs of hyperacute myocardial infarction. Here in this picture, you can see this hyperacute changes. You can see tall T waves, they are broad T waves, and also you can see they are slightly wide, they are taller than the R waves of the same wave. So this typical picture of hyperacute MI. So any patient, if you see who is having cardiac symptoms and this tall T waves, you need to keep in mind that it could be hyperacute MI. You have to admit the patient or repeat the ECG to see what is the condition of the patient and the ECG changes. So just as this is the acute ST elevation MI, as I mentioned, this you can see the ST segment getting elevated in all these leads. Regarding localization, I'll be telling in my future slides. So this is a typical acute ST elevation myocardial infarction. So this is a slide showing the myocardial necrosis. So we saw the three slides, one of hyperacute MI, one is acute MI, and this is an old MI with myocardial necrosis. It is reflected electrographically by QRS negativity and loss of positivity in the leads orient to the infarcted region. So there can be QS. So as I mentioned here, so these are the QS complex. The Q wave and S wave together, they form a deep negative wave, which is called as a QS complex. So these QS complex and loss of R wave amplitude are important signs of an old MI. So I think by now all of you should know hyperacute MI, tall and wide T waves, ST segment elevation with increased QRS activation time, acute MI with ST changes, T wave inversion and Q waves, and myocardial necrosis, there is a QS complex and loss of R wave amplitude. So coming to our slide on non-STEMI. So in all these slides, we saw ST segment going up, but in some cases where there is ST segment, there is no elevation, but patient has cardiac complaints. So there can be ST segment depression. It can be a new horizontal ST depression or a downsloping ST depression. It could be horizontal, upsloping, or downsloping, which we'll discuss later. And T wave inversions of more than 1 mm in same two or more contiguous leads, and this R by S ratio of more than 1. So whenever you're getting STT changes without having ST elevation, in fact, you have ST depression or T wave inversion, we have to think of either it could be NSTEMI or it could be unstable angina if the chest pain is ongoing. So the difference between NSTEMI and unstable angina is the cardiac enzymes. When NSTEMI, cardiac enzymes are elevated, whereas in unstable angina, these are not elevated. So this is a picture showing ST depressions in V1, V2, V3. So these are suggestive of NSTEMI. So now coming to the infarction per se and localization of the MI, the culprit artery. So myocardial infarction, I'm sorry, there's a typing mistake. Myocardial infarction usually involves a left ventricular cone, sometimes involves the free wall of the right ventricle also. So coming to the infarction of the left ventricle per se. So left ventricle, for practical and clinical purpose, we divided it into three areas. One is the anterior wall, inferior wall, and the posterior wall. So here we have to know a little bit about the coronary arteries for us to localize the lesion. So there are two coronary arteries, that is left coronary artery and right coronary artery. The left coronary artery originates from the aorta. After coming out, it divides into two branches. One is called as the circumflex branch and other one is left anterior descending branch. Sometimes there can be a third artery called as a ramus intermedius artery also in some people. So left anterior descending artery, it has septal branches which supply the anterior two-thirds of the septum, And there are lateral branches which supply the anterior wall of the myocardium. And in some patients this goes further down, and there it can also supply the, in some patients, the inferior part of the heart. Left coronary artery supplies the lateral portion of the myocardium, whereas the right coronary artery originates from the aorta and it supplies the right ventricle and also the posterior part of the myocardium. So, left anterior descending artery infarctions usually cause large MIs. It supplies the anterior wall, the lateral wall, anterior two-thirds of the septum, and frequently the inferoapical segments of the left ventricle, and even the proximal part of the bundle branches. Whereas the right coronary artery perfuses the sinus node in around 55% of the patients. It perfuses AV node, posteromedial papillary muscles, inferior part of the left ventricle, right ventricle also. Circumflex artery, which supplies the posterior wall and variably inferior and the lateral segments. Posterior wall involvement, which is generally underestimated, which I'll be discussing next slide. So dominance. So we should know about something regarding the dominance of the arteries. So what does this dominance mean? So the vessel which gives rise to the posterior descending artery, that artery is called as dominant. So generally we have the right coronary artery in around 70% of the patients. It gives the posterior descending artery. Left circumflex artery in around 10% of the patients, and sometimes it can be co-dominant in 20%. So coming to branches, as I mentioned, so left anterior descending artery has a diagonal branches. It has septal branches. Circumflex artery will have the marginal branches, that is M1 and M2. Right coronary artery, this is important for you. There will be a conus branch, sinoatrial branch, right ventricular branch, acute marginal branch, and an AV nodal branch. And if the right coronary artery is dominant, then it will give rise to posterior descending artery. So this is important slide for you to localize the MI. So as you all know, these are the leads showing. I think all of you know about this. This is V1 to V6, and here we have lead 1 for the left side, lead 2 and lead 3, AVL, AVR and AVF. The orientation of the leads is important for us to know the territory of the LV involved, and also to describe which is the artery which is involved. So first and the most extensive MI is the extensive anterior wall myocardial infarction. As it shows, it is extensive. So it involves whole of the leads, whole of the left ventricle, as evidenced by V1 to V6. In all the 6 leads, they will be having ST segment elevation. And also there will be elevation in lead 1 and there will be elevation in lead AVL. So 1 AVL, V1 to V6, there is ST segment elevation. Anteroseptal, so where there is anterior part of the heart and also the septal part. So this region, so here there is involvement of V1, V2, V3 and V4. Anterolateral, as evidenced by the lateral leads, that is 1, AVL, V5 and V6 are we've seen anterolateral MI. Apical wall MI, where only the apex of the heart is involved, you see ST changes in lead V5 and also in lead V6. High lateral in few patients, in very extremely high lateral most part of the myocardium, where there is involvement of only lead 1 and AVL. So this localization is important for us to know and prognosticate the MI of the left ventricle. So we talk about the reciprocal changes. So the leads which are facing directly will have the ST segment vector facing towards them, where there will be ST elevation. Whereas in the diagonally opposite leads, since the vector is in the opposite direction, you will have ST depressions. So if this inferior wall MI, so 2, 3 AVF will have ST elevation, whereas 1 and AVL will have reciprocal changes. Anterior wall, V1 to V6, V1 to V4 generally, but reciprocal changes will depend on the extent of the injury and also which part of the myocardium is involved. So reciprocal changes may be restricted only to 1 or 2 leads towards in that particular region only. Septal branches, septal infarction, V1, V2, and also the reciprocal changes will be V7, V8, and V9. So coming to anterior wall MI, occlusion of LAD or LMCA, that is left main coronary artery, causes anterior wall MI. So type of occlusion could be a proximal LAD occlusion where there is extensive MI, or there can be a mid LAD. Either it could be proximal to the septal branch or proximal to the diagonal branch. Both of them we together called as mid LAD lesions, and a distal LAD lesions where mostly the apex of the heart may be involved. So this is a ECG here. A 50-year-old gentleman, chronic smoker, diabetic since 10 years, complains of retrospective chest pain since 1 hour. Pain was constricting type with vomiting and severe diaphoresis. So anyone can interpret this ECG. If Vijay Balaji, if you are there, you can attempt this ECG.
Yes, sir. This is a well-standardized ECG with normal sinus rhythm showing ST elevations in one AVL V1 to V6. So it's an extensive anterior wall MI with reciprocal changes in the inferior leads.
Good, thank you. So as you can see, there is extensive MI. There is ST elevation in lead 1, ST elevation in lead AVL, and V1 to V6, and there are reciprocal changes in lead 2 and lead 3, and even in AVF. So whenever you see ST elevation in 1 AVL V1 to V6, we term it as extensive acute myocardial infarction, where the lesion involved is in the proximal left anterior descending artery. So it's an extensive anterior wall MI, proximal LAD, which is proximal to both septal and diagonal branches. So this is another ECG where you can see anterior wall MI. There is a special point here. You can see a VPC here. So in this segment, there is a VPC. It's a ventricular premature complex. It's a very important sign because there is an RNT phenomena happening here. So without the coupling interval, there is a VPC. So this is very important because whenever you see a VPC, it's on ECGs. Generally, it shows a poor prognosis. And generally, if there is an RNT phenomena happening, this shows that the myocardium is highly injured and it is prone to develop ventricular tachycardia, which is a very serious and life-threatening arrhythmias. So this is another ECG which is showing extensive AMI. There is ST elevation in lead 1, lead AVL, V1 to V6. This ECG I have put just to show you the tombstoning pattern. This is a typical tombstoning pattern which you see in all the leads from V1 to V6. So this ECG, Vijay Balaji, can you attempt?
Yes, sir. This ECG, it is showing biphasic ST elevations in the anterior leads with some biphasic T waves in V2 to V3 with ST depressions in AVL, with preserved ST depressions. There's no reciprocal changes in the inferior leads.
Okay. So generally this depicts a anteroseptal MI. So where there is involvement of V1 to V3. So this is an important slide, especially postgraduates can pay attention here. So proximal LAD occlusions, you have ST depression in the inferior lead since there is a reciprocal changes, ST elevation of more than 2.5 millimeter in V1. There can be right bundle branch block or left anterior hemiblock and ST elevation in AVR. So this is very important for you because whenever you see an extensive AMI, please look at if there is a RBBB there. Generally, it shows a poor prognosis. And if there is elevation of ST elevation, it shows a very proximal occlusion. Almost it can be a left main coronary artery occlusion also. And also whenever there is ST depression in inferior leads, it shows extensive MI, which has led to this reciprocal changes in the inferior leads. Lower down, as you go distal, in the mid LAD lesions, you can have ST elevation in 1 and AVL, which leads to which is because of the occlusion of the lateral branches, and distal LAD occlusion, where usually there will not be any reciprocal changes, and there will be ST depression in AVL. So this is an ECG. Especially for postgraduates, it's important. You can see there are widespread ST depression. So there are ST depression in many of these leads. But if you look at carefully in lead AVR, there is an ST segment elevation. So it apparently looks that there is no major ST elevations, but this is one of the very threatening ECGs because there is an ST elevation in AVR and widespread ST depression in the other leads. So this is a typical feature of left main coronary artery occlusion. So it's a very dangerous occlusion. So, but there will be just widespread ST depressions and there will be ST segment elevation of more than 1 mm. Why I'm telling you this is because the AVR is almost like an ignored lead, or most of us do not pay attention to the AVR and we are more focused on looking at the other leads. But if you see AVR, if there is ST segment elevation and there are ST depressions, so it has to be taken very seriously because it could be an occlusion of left main coronary artery. So this is an important slide to tell you how important the ST elevation in AVR is. In the context of widespread ST depression and symptoms of myocardial ischemia, ST elevation of more than 1 mm indicates proximal LAD block or even LMCA occlusion. In some books, they tell ST AVR elevation is seen in proximal LAD also. ST elevation in AVR of more than 1 mm predicts the need for CAG, CABG. So if ST elevation is there in AVR, patient definitely needs coronary artery bypass graft. And generally, absence of ST elevation in AVR rules out significant LMCA lesions also. So AVR has a lot of propensity to tell you whether the occlusion is at the left main coronary artery or it is at the proximal LAD also. ST elevation in AVR is specific for LAD occlusion, proximal branches. And it also, if there is ST elevation of more than 1 mm during a TMT or exercise test, it predicts LMCA and LAD stenosis. This is other question usually for the postgraduates, it can be asked. So what are the other causes of ST segment elevation? So in AVR. So ST segment elevation in AVR can be seen in proximal left anterior descending artery occlusion also. It can be seen in severe triple vessel disease and also sometimes diffuse subendocardial ischemia, either due to decrease in oxygen supply or following a cardiac resuscitation. So this is an important question for you all. So yeah, so this is an important concept once again. So what are these De Winter T waves? So De Winter T waves have been described quite late, like around in 2008, electrophysicist and a physician, De Winter identified these waves. They look apparently not so significant because there is an upsloping ST segment and there is a peak T waves. But these De Winter T waves are very important because they predict the critical LAD stenosis. So what are De Winter T waves? It is an upsloping ST segment and a tall and pointed T waves generally in the leads of V1 to V3. So these De Winter T waves are seen in around 2% of the case of acute LAD occlusion. So the important thing is unfamiliarity with this high-risk ECG pattern leads to undertreatment. So even if you see a upsloping ST segment depression, which is generally considered benign, and just upright T waves in the anterior precordial leads, you have to take it seriously because it could be a critical LAD occlusion. So here once again, you can see upsloping T waves and a tall, it looks like an hyperacute MI. So these are called as De Winter T waves. So this is another ECG. A 48-year-old gentleman with history of chest pain presented with complaints to emergency since 30 minutes, was told to have a normal ECG and cardiac enzymes negative. Patients reviewed next day in the cardiology OPD, and this was the ECG. So here you can see a patient had come who was told to have a normal ECG and normal cardiac enzymes and was sent home. After a few days or after next day, when you see his ECG is showing something like this. So this is also a very critical ECG and ECG which is very likely to be missed because of which it generally looks quite benign because there is no ST elevations. But if you look at carefully, we have something called as a Wellen syndrome, where we have something called as type A Wellens, where you can see biphasic T waves. So biphasic T waves are a little bit is positive and a terminal part is negative. So this biphasic T waves is called as type A Wellen syndrome, and type B Wellen syndrome is once again symmetrical T wave inversion in the anterior precordial leads. So both these changes are called as Wellen syndrome. Wellen syndrome is very important because the patient generally appears pain-free and is hemodynamically stable, but it is generally an acute tight LAD occlusion. So once again, I'm telling, so Wellen syndrome patients will be having, apparently they don't have chest pain when at presentation, they will be hemodynamically stable, and there will be little or no biomarkers, cardiac biomarker elevation, but it is an acute and tight left anterior descending artery occlusion. So this is very important. So once again, I'll show you, this is the type A valence where there is biphasic T wave, and type B valence where there is inverted T waves. So now coming to a little bit about the vector of the MI, so that if you understand this, it's very easy for you to predict the ST elevations. So if there is a proximal LAD or a LMC occlusion, so this is a left main coronary artery occlusion. If there is occlusion, so the injury vector is pointing towards the direction of AVR. So that's why you will have a positive AVR, whereas all the other leads will be negative. As I mentioned earlier, as an left main coronary artery occlusion, so this there's ST elevation in AVR and depression in all other leads. So this is a typical picture showing ST elevation in AVR, and this is a direction of vector. So here you see a LAD occlusion slightly lower than the LMCA. So this is a typical area where the LAD occlusion proximal happens. Here you can see the direction of vector is pointing in this direction. So that's why you see positive ST elevation in lead AVL and lead 1, whereas there will be slight ST elevation in AVR still, but you will see diffuse like ST segment depressions in lead 2, lead 2, lead 3, and AVF. So this is a typical picture you see in proximal LAD occlusion, where ST elevation is 1 AVL and other chest leads V1 to V6, but there is ST depression in lead 2, lead 3, and AVF. This is a mid LAD occlusions. In this direction, the vector points. So you will have ST elevation in lead 1 and lead AVL. At the same time, you will have ST segment depression in lead 2, lead 3, and AVF. So this is a picture where it shows a mid LAD occlusion. So this is a distal LAD in the downward side. It's the more distal part of LAD. So in this direction, so you will have ST elevation in lead 2, ST elevation in lead 1, whereas there will be ST depression in lead AVR. So it's a diagonally opposite. So these are the distal LAD lesions. So if you know these vectors properly, so you can easily predict, and there is no need for you to by heart these changes or mug up these changes. So this is a beautiful clock showing. So this direction is the vector of LMCA. This direction of a vector in proximal LAD, mid portion of LAD, and distal portion of LAD. If you know this diagram, so you will easily remember the ST changes and localization of the artery. So now coming to the inferior wall MI. So the inferior wall of the left cone is oriented towards the region of lead 2, lead 3 AVF. Hence, ST changes will be in the inferior leads only. Inferolaterally, sometimes there will be infarction where there is an additional involvement of lead V5 and V6. In 80% of the patients, the inferior wall of the heart is supplied by the right coronary artery via posterior descending artery. In other 20%, it is the left circumflex artery. So for practical purpose, you should remember that inferior wall MI is caused due to occlusion of the right coronary artery. Approximately 40% of inferior wall infarctions also involve the right ventricle. So whenever, this is an important statement. So whenever you see inferior wall MI, in around 40% of patients, there can be involvement of the right ventricle also. The right coronary artery perfuses the SA node, heart blocks and bradycardia may happen. So in any patient who is presenting with chest pain, and if you see a bradycardia, you have to think of an inferior wall MI, and you should repeat the ECGs later on also. A high degree heart block, defined as second or third degree heart block, can be seen in 19% of patients. If there is concomitant disease to the other coronary, then likely circulation to the AV node will also be affected. So take home message from this is inferior wall MI, you have to suspect even heart blocks. Heart blocks can happen, bradycardia can happen, and around 40% of the patients, there will be involvement of right ventricle also. So this is a region. So this is the right coronary artery which supplies the inferior wall of the heart. So these are the three leads, lead 2, lead 3 and AVF. So this is a patient, a scenario, 49-year-old female present with emergency room with persistent vomiting. One more important part of inferior wall MI is it generally causes epigastric pain and vomiting. So in any elderly man or any patient who has persistent vomiting or epigastric pain, you have to do an ECG to rule out inferior wall myocardial infarction. So in this ECG, you can see there is ST segment elevation in lead 2, in lead 3 and in lead AVF, and there are reciprocal changes in V1, V2 and V3. So this is important because whenever you have ST segment elevation, as I told, you have to think of the involvement of the right ventricle also. For the right ventricle, there has to be ST elevation in V1 and also lead called as V4R, which is generally put on the right side of the chest. So here I'll mention, so in this patient, there was ST elevation in lead 2, lead 3, AVF, ST depression in lead 1, ABL, V1 to V3. So now looking back little bit more carefully now. So here you should see whether it's the lead 2 or lead 3. So in which of the lead the ST elevation is more prominent. Here you can see ST segment elevation is more prominent in lead 3. So whenever there is lead 3 is more elevated than lead 2, it is likely to be right coronary artery. So hence this is a region of RCA occlusion. So this is an important slide. Kindly pay attention to this slide. So whenever you see an inferior wall MI, first look at lead 2 and lead 3. If ST segment elevation in lead 3 is more and there is ST segment depression in lead 1 or AVL, so you should suspect a right coronary artery occlusion. So whenever there is right coronary artery occlusion, you have to immediately look at V1. If there is ST elevation in lead 1, and you should put a lead V4R, that's on the right side of the chest. If there is ST elevation in V1 and AVR, both of them suggest that it's a proximal RCA occlusion with right ventricular infarction. So once again, I'll tell ST elevation in lead 3 more than lead 2 along with reciprocal changes. Look at V1 and V4R. So if all these three things are there, and that is a proximal right coronary artery occlusion along with right ventricular infarction. Coming down here, if you see there is ST elevation in lead 2 is more, then it is most likely to be involvement of the left circumflex artery. So this is an important slide pertaining to the inferior wall MI. So same thing portrayed here. RCA occlusion, lead 3 is elevated, is more than lead 2. Reciprocal ST depression in lead 1 and lead AVL. And there is ST elevation in V1 and V4R. Whereas these things are absent in left circumflex artery occlusion. So coming to the posterior wall myocardial infarction, as you all know, we don't have any conventional lead to place on the back to look at the posterior wall. So hence we diagnose posterior wall MI by looking at the mirror image of the changes. So once again, posterior wall MI must be suspected in all the patients with inferior wall MI, as I mentioned. Posterior wall MI occurs when posterior myocardial tissue is thrombosed, and most in 80% of the individuals, it is the right coronary artery. So how to diagnose posterior wall MI? So for posterior wall MI, look at lead 1 and lead V1 and lead V2. In lead V1 and V2, there will be a tall T wave, slightly broad, a tall R wave, slightly and a little bit broadened R wave duration, and there is an ST segment depression, and there is an upright T wave. So once again, tall and slightly wide R wave, ST depression, and a upright T wave. This R by S ratio is more than 1. So you can see here, R wave is longer than the S wave. So if this ratio is more than 1, so all these three things together tell that it is a posterior wall MI. So a tall and slightly wide R wave, RS ratio of more than 1, ST depression in V1, V2, V3, and an upright T wave. So all these together confirms it is a true posterior wall MI. So here you can see The same thing here, R by S ratio of more than 1, ST depression and upright T wave. So if you see this in the mirror image, this looks like a typical MI with a deep Q waves, ST segment elevation and a T wave inversion. So this mirror image concept you should be knowing, and you should be knowing these 3 points to diagnose posterior wall MI. And most important is suspecting posterior wall MI, because most of the people will miss posterior wall MI. So this is a picture. 54-year-old man presents with sudden onset of retrosternal chest pain associated with nausea and diaphoresis. So here you can see the ST segment elevation in lead 2, lead 3 AVF. Okay, happy. There is an inferior wall MI. So here, as I told you, you look at the lead 2 and lead 3. So lead 3, there is increased ST segment elevation. So now there is reciprocal changes in lead 1 and AVL also. So immediately look at V1. If lead 1 is showing R and S wave of more than 1, R by S of more than 1, ST depression and T wave, upright T wave. So this is a typical picture of an RCA, proximal RCA occlusion with inferior wall MI and the posterior wall MI. So as I mentioned here, so same thing, vessel involved is right coronary artery. So now coming to the infarction of the right ventricle. So once again, infarction of the right ventricle is very rare. And it is not identified because of the small mass of the right ventricle, low tension within the right ventricle, and rich collaterals in the right ventricle. But still, RV infarction has to be suspected in any patients with inferior wall MI. RV infarction should be strongly suspected this is important for all of you, if the inferior wall MI, if the ST segment elevation is more than 1 millimeter in V1. So whenever there is ST elevation of more than 1 mm on V1, ST elevation in lead V1 and ST depression in V2. This is important. It's called as discordant relation, where there is ST elevation in V1 and ST depression in V2. So these two are important points. So once again, ST elevation of more than 1 mm in V1 and ST elevation in V1 and ST depression in lead 2 in V2. So this discordant change. And also third one, if you are interested to know, in inferior wall MI, if ST depression in lead V2 is less than 50% of the ST elevation in lead AVF. It's slightly difficult to interpret, but these two are practical points to you to remember to suspect right ventricular MI. So whenever you see this, you have to put the leads on the right side of the chest and see all the leads and diagnose right ventricular MI. So why are we supposed to diagnose this right ventricular MI? Right ventricular infarction complicates up to 40% of patients with inferior MI. So 40% is quite huge number. So patients with RV infarction are very preload sensitive because of poor RV contractility. They develop severe hypotension in relation to nitrates. So especially if you have RV infarction, please do not give nitrates or diuretics. Rather, you should give them with fluids. So you have to treat them with IV fluids because there will be some amount of hypotension, but do not give nitrates. So that's why to prevent this complication, so significance of identification of RV MI is very, very important. The first step to identify RV infarction is suspect in all inferior wall MI patients. As I mentioned you, look at ST segment elevation in V1. If lead 3 is more than lead 2, then definitely look for the right ventricular MI. And then you look for the right ventricular leads. So this is a picture showing. So once again, ST elevation in lead 2, lead 3 and AVF. ST elevation is more in lead 3. There are ST segment depression in lead 1 and AVL. Now look here. So now there is ST elevation in lead 1 and ST elevation in lead 2. In these circumstances, you have to do a V4R and put the leads on the right side of the chest and see for the right ventricular MI. So this is summary here. I think it is given in most of your books regarding the all the MIs: anteroseptal V1 to V4, anterolateral 1 AVL V2 to V4, anteroapical extensive MI as I discussed, lateral wall MI, and then the most important, that is the LMCA occlusion. At the same time, here you should remember the De Winter's T waves and Wellen syndrome. Inferior wall MI, where we have to know whether it's an RCA occlusion or LCX occlusion, and posterior wall MI, which is generally associated with inferior due to the occlusion of right coronary artery. So looking at ECG of MI, when can you tell that this patient is at high risk of death? So you have seen the ST segment elevation, depressions, reciprocal changes. Now, if there is an extensive MI, either it could be an extensive anterior wall MI and extensive RCA, that is the proximal RCA occlusion, both are very dangerous. So if at all, if you read the books, it is given that anterior wall MI are more dangerous than inferior wall MI because the arrhythmias arising out of the anterior wall MI tend to be very bad and they precipitate into VT and VF. So hence anterior wall MI are very dangerous, especially if it is extensive. Multiple infarctions. If a patient already had an MI and upon that there is another MI, it's a very bad prognostic sign. If there is an associated bundle branch block, especially if there is an LBBB, it is a very poor prognostic marker. Ectopic rhythms, as I mentioned, if you see frequent ventricular premature complexes, VPCs with the bigeminal rhythm, VPCs, multifocal VPCs, VPC with short coupling interval where we call it as R on T phenomena. So these are frequently increasing in the order of the severity. So VPCs, whenever you see in ECG, are a bad sign, especially if there is a short coupling interval which we call as R on T phenomena. If there is an RNAV block, it's a bad prognostic sign. And in general, anterior wall infarctions are much bad than inferior wall infarctions. As I mentioned, that the arrhythmias originating out of the anterior wall have more unstable arrhythmias. So coming to the atrial infarctions. So atrial infarctions are once again very rare. There is something called as a PTA segment, the segment from P to T. So this PTA segment is elevated, sometimes difficult to identify, but other easy methods are you can see the widened and notched P waves. So whenever you see P wave abnormalities in a patient with extensive MIs, either it could be a widened P wave or it could be a notched P wave, it is a sign of atrial infarction. Abnormalities of atrial rhythms, it could be atrial extrasystoles, it could be atrial flutter, or it could be sinus arrests. So any of these things suggest that it is a atrial arrhythmias due to atrial infarction. If there is a sinoatrial block and even the first degree AV block. So all of these things are important. Especially these things are asked in many of the MCQ questions where they give you a scenario where there's an elevated PTA segment and a widened and notched P waves. Coronary insufficiency. So now we have dealt with the ST segment elevated MIs. Now a few slides on coronary ischemia. So whenever there is coronary ischemia, four things can happen as I mentioned in the earlier slides. There can be ST segment elevation and there could be ST segment depression. You'll be surprised that even though there is no infarction, how can there be ST segment elevation? So there is one entity called as vasospasm or Prinzmetal's angina, where there is a vasospastic change. So this vasospasm can cause ST segment elevation. But apart from this, most of the time coronary ischemia manifests as ST depression. Apart from that, there will be T wave abnormalities, usually inverted T waves, and there can be some QRS and QRS changes, which I'll be telling later. So there are four types of ST segment depressions. Straightening of the ST segment, where the ST segments just become straightened. It can be upsloping, or it can be horizontal depression, or it can be downsloping. I have a picture here to show you here. So here it is an upsloping, here it is a horizontal ST depression, and there is a downsloping ST depression. Generally, horizontal and downsloping are considered to be more pathological. In some patients with tachycardia, there can be some amount of upsloping ST depressions. So as I mentioned earlier, ST elevation coronary ischemia can happen because of coronary vasospasm, or there can be severe stenosis of the coronaries. So even this can cause ST segment elevation, even though there is no evident ischemia, no evident infarction, sorry. And an LV aneurysm can also have ST segment elevation. So T wave changes in coronary ischemia. As I told, it will be a sharp and pointed T wave, inverted, and with the symmetrical limbs. So now coming to the abnormalities of the U waves, you'll be wondering now how are U waves important for us? Yes, in some conditions, not in all, but you should be aware of these things. So U wave is a small rounded deflection just after T wave. It usually has the same direction of T wave. So if the T wave is positive, even U wave will also be positive. Usually seen in V2, V3, and V4. It is important. I'll show you a U wave and then we'll go back. So this is a T wave and this is a U wave, but here there is a inversion of U wave. This is small negative wave which you can see. Generally, this is positive, so this U waves are upright. But in this ECG, U wave is inverted. Now going back, inverted U waves is diagnostic of cardiac disease, especially coronary ischemic heart disease. So if you see an inverted U wave, it is highly specific that there could be a ischemic heart disease underlying. Or also appearance of U waves after exercise indicates there is ischemia. So once again, I'll tell you. So the U waves generally appear after T waves. Generally, they are upright, but an inverted U wave is a sign of myocardial ischemia. And also appearance of new U waves after exercise also shows that there is an underlying ischemia. So now coming to the last part of the presentation, we'll discuss some of the ECGs where it looks like an MI, but generally there is no MI. It is called as benign early repolarizations. So benign early repolarization generally causes ST segment elevation. You can see here ST segment looks elevated, but carefully if you see here, there is a notching or a notching after J point. So these are the J points. There's a slight notching. So this is called as a fish hook pattern. So whenever you see this fish hook patterns, it is called as J point evaluation or a benign early repolarization. This is generally seen in young patients and more in females. It is a benign phenomenon. So now coming to one of the arrhythmia, that is the Brugada syndrome, where there is ST elevation in V1, V2, V3. So this is unstable. It's an arrhythmia generally. It precipitates into VT. But one of the important differential diagnosis of ST elevation is a Brugada syndrome. So here these ST elevations are dangerous. It can precipitate VT, and generally treatment is given by preventing the arrhythmias by implanting ICDs. This is important, as I mentioned. So there is an LBBB here. So identifying MI with LBBB is quite challenging because most of the times LBBB can mask all the changes of MI. So here we have a criteria called as the Garbosa's criteria. So there are 3 points here. There is concordant ST segment elevation, concordant ST segment depression of, we will see here rather it will be more clear for you. So yeah. So this is a see here, this is a deep S wave, and there is a more than 5 mm elevation here. So this is a discordant ST segment elevation of more than 5 mm. And here is a concordant ST segment elevation because the QRS is positive direction and T wave is also in the positive direction. So here this is concordant ST segment elevation. So here going back, looking at the criteria, so the concordant ST elevation of more than 1 mm with positive QRS axis, this carries a score of 5. Concordant ST segment depression of more than 1 millimeter in V1 to V3, it carries a score of 3. And excessively discordant ST segment elevation of more than 5 mm carries a score of 2. If the score is more than 3, it is called as significant. So this is a very well-known criteria called as Garbosa's criteria. Now this is an important drug, digoxin, which is generally given with many patients having cardiac failure. Even digoxin can cause ST segment depression, and one of the important toxicity of digoxin is arrhythmias. So here you can see this ST segment depression here. So one question which is very commonly asked is how to differentiate the ST segment depression of digoxin toxicity from the ischemic ST segment depression. So as I have mentioned here, the digoxin toxicity, the ST segment will be a downsloping ST segment will be there, but there will be a slight deepest part will be in the most lateral part of the lead, which causes a reverse tick mark sign. So it looks like a tick mark here when you see it inverted. So it's called inverse tick mark sign, which is most classical of digoxin toxicity. And what is also mentioned in some books is the ST depression here. In general ischemia, there will be a slight dip from the isoelectric line, and then the ST segment depresses. Whereas in digoxin toxicity, it remains at the isoelectric line. So this inverse tick mark sign is probably most important indicator. So coming to the last slide now, acute pericarditis. So one of the important differential diagnosis of ST segment elevation is acute pericarditis. So even in acute pericarditis, where you see widespread ST segment elevations, here you can see this widespread ST segment elevation in all the leads. So one important question is, how do you differentiate ST elevation of acute pericarditis from ST elevations of myocardial infarctions? So general acute pericarditis, ST elevation are seen in most of the leads, and these ST segments will be convex upward. There are smiling ST segment elevations. So generally, these are not very much suggestive of infarctions, whereas the frowning ST segments are most significant for for ischemia. So widespread ST segment elevations where there is concavity upwards is most important. And also in acute pericarditis, you do not see the reciprocal changes, and you usually do not see the T wave changes also. Also, one important point is, as the time progresses, these changes change. So the ST segments do come to their normal shape. And also there is something called as PR segment. So this PR segment also depression. So this PR segment depression is also a sign of acute pericarditis. So once again to revise, so ST segment is widespread, elevation is widespread in pericarditis, whereas it is more localized in MIs. The ST elevations are more concave upwards, that is the smiling ST segment elevations in acute pericarditis, where there are more frowning or concave upwards, convex upwards in myocardial infarctions. T wave abnormalities are generally not much seen in pericarditis. Reciprocal changes may not be seen in pericarditis, and depression of the PT segment is not a well-established sign of is seen in acute pericarditis, whereas it is not seen in acute myocardial infarctions. So these were few ECGs where you see the ST elevation mimics or ischemia mimics, where one of is acute pericarditis, digoxin toxicity, LBBBs, and Brugada syndrome, and benign early repolarization syndromes. So with these things, I think I'll end my presentation today. So thank you for a patient hearing. Do you have any questions, anyone? Or Balaji can help me to tell if any questions are there.
As of now, there are no questions, sir.
No questions. Okay. Okay. Shall we end the class? Okay.
No questions on YouTube as well, sir.
Okay. Okay. Fine. Fine. Thank you. Then I'll stop my presentation.
Thank you, sir.
Thank you.
Thank you, sir.